Welcome back to the podcast on non-interpretive skills and radiology. And today we continue our conversation on MRI safety with Stephen Mercedes. My name is Nadia Kedem, and let's dive right in. We deal a lot with implants, cardiac devices, hearing aids, and things like that. I know that there are solid websites where we have information where testing has been performed for each and every single device and indicating whether it's safe or unsafe or conditional. So I think it's intuitive to know MRI safe means you can scan it the regular way. Unsafe means should not go in the scanner. But what about this conditional? What do we do with these conditional devices?
That's a can of worms, I'll tell you. So, one thing to remember, and this is something that was highlighted to me by another physician and really an expert in this field. He had said that when it says that it's not FDA approved for the MRI, that's not to say that it is illegal. Not FDA approved does not equate to being legal. All it signifies is saying that we just don't know. It could be perfectly safe. There could be no issues. It's MRI safe, but we just don't know. Not enough testing has been done on this particular implant to know what it means. And this is where a lot of the gray areas come in, and a lot of the technologists have to use their expertise as well, along with their resources that's available to see what do we do in these situations. So going back to what you had mentioned with MRI unsafe, clear, like you mentioned, safe, these are things that have been tested. Now, conditional, what that means is that it has been tested in certain conditions. And it's so funny that you mentioned this because just this week I had something that's relatively new. And this is the sleep apnea device that it looks like a pacemaker, right? It has a generator, it has leads connected to the diaphragm and then to the vagal nerve. And it's one of those that looks like a pacemaker. I had the MRI card, and when I read the card, it almost confused you more than it gave you answers. Right? What it ended up being is that it was safe or conditional at a 1.5 magnet with a transmit receive coil scanning only the head, meaning this is all that was tested. And we don't know anything else after that. Anything else that you decide to do as a practitioner, as a specialist, is totally on you. As we know, a lot of these things require money, these testings, and they don't want to invest the money. And what happens is after 5 or 10 years, a lot of practices have done these exams on these patients under different circumstances. Yeah, we've done them under 1T, we've done them on 3T, nothing has happened. And then they present this to the FDA, and the FDA says, you know what, we have enough information to say that now it's conditional at these situations. So I just want to highlight that the conditional, it's a gray area and it can be confusing. But I think this is where the MRI technologists, MRSEs, MRMDs have to use their expertise as subject matter experts and really dig in to see what are we doing, how are we doing this, and all these questions have to be asked.
It's interesting that you mentioned that because I know in the past, at least, what I learned is when a patient comes in with a device and we don't know anything about it, we don't know if it's safe or not, but they say, oh, but I had an MRI last month at a different hospital and nothing happened. People want to consider that as a sign of this device is safe. But what I learned is that you can't do that. You really have to do your due diligence. If you can't find out what exactly the device is, whether it's safe or not, you may not be able to do the MRI. Is that still accurate?
That is absolutely accurate. I always think back to the story when I was a kid. I was about 10 years old and I was in the vehicle with my mother. There was a sign that said, do not turn on red. This was back in New York. And sure enough, a bunch of cars turning on red. And my mom went ahead and turned on red, and the police officer stopped her. And as soon as he came to the window, he asked her, why did you turn on red? And she said, everyone else did. But she was the one that was stopped. She was the one that was given the ticket. Just because everybody else has done it is not necessarily the best excuse. It doesn't mean that when you decide to scan them, that it's going to go just fine. It should not be an indicator to say, I'm okay to scan them if they've been scanned before. That's absolutely correct.
Yeah, yeah. And then what do you do when the patient is unconscious? Let's say a trauma patient comes in, we don't know anything about them, they don't have a medical record with us, but I need an MRI scan. How do we go about assuring safety for a patient like that?
Yeah, yeah. The first step, obviously, if we can get a hold of a family member, I always say try to get a hold of somebody that's familiar with the patient. This is the first step. Now, is it the most reliable? I would say no. I can ask my wife what she knows about me and my surgeries, but she's human, right? She's subject to error as well. So this is where we go back to diagnostic x-rays and CTs. I think those are the best options and safest choice for clearance. The technologists should also use their visuals, look for scars, look for things that are clear indicators of saying, this looks like he had a surgery. This looks like he has sternal wires of some sort. All of these things that diagnostic x-rays and just using visuals are extremely important.
Yeah, an X-ray technique now is so low dose that nobody should really consider that a hazard.
Absolutely.
The other thing I remember that has always been an issue are aneurysm clips. And because I'm older, I think before the 2000s, there were certain aneurysms clips that were used that were actually ferromagnetic and dangerous. But my understanding is that since 2000, every aneurysm clip out there, at least in the United States, should be MRI safe. Is that true, or how do we go about aneurysm clips?
That's a great question. MRI safe, I would say, is more of a little bit of a stretch. I would say they're all MRI conditional in
Hmm.
the sense of, yes, you can scan them under certain conditions. If someone has had an aneurysm clip, I try to dig in as much as I can, even if it's somewhere where it was in a different state at another facility. We try to get those medical records to be on the safer side. With pediatrics, because they're the newer implants, I'm not concerned too much about that. But the older patients who have possibly had an aneurysm clip placed before 2000, definitely I try to dig in as much as information as I can. But to say that they're MRI conditional, I think is more appropriate. Yes.
Okay. And then for the cardiac devices, there are a huge array of cardiac implantable devices, or CIEDs, cardiac implantable electronic devices. And thankfully, the more modern devices are all much more compatible with MRI, where you don't have to be so fearful. And I think there's emerging literature now that many, even of the older devices, are safe to go into the MRI under certain conditions. But we also at our institution have a very nice collaboration with cardiology when it comes to these devices. Can you talk a little bit about the clearance process?
Yeah. I'm very fortunate to work closely with the cardiology and electrophysiology. They are extremely good resources to use when it comes to CIEDs, cardiac implanted electronic devices. Yeah, they are the experts in this matter, right? And a lot of the times, even as MRSO, I reach out to one of the EP practitioners and they go through everything, even the MRI safety portion of it. A lot of these patients are cardiac dependent. And if something was to happen, and this is more so related to the gradient energy and it flipping and causing electrical currents in these leads and generators, it can be really detrimental to these patients. Over time, I'm sure it'll change. As of right now, if there are cardiac implanted devices that they're cardiac dependent, we're a little bit more hesitant. But I'll be honest with you now, patients who aren't just dependent on this device, the screening process is a lot less stringent now, as long as they're turned into this MRI safe mode or MRI scan mode, whatever it's called, and they're put on a steady pacing rhythm. Once they're put on this rhythm, then that generator is only going to be pacing at that same just the whole time, no matter what. So there's a lot less risk, and again, studies have shown that they're becoming a lot more conditional. Before, when the pacemakers were, they looked like you had a book in your chest, right?
Yeah, yeah,
That's what I remember seeing.
yeah.
Now, some of them go inside the heart and they're the size of a battery. You won't see it. So it's getting better. And along with that is the MRI conditionality as well.
Yeah. And I know from the physician end, when we do check out these patients prior to their scheduled appointment for the cardiac situation, like you mentioned, whether they're dependent or not on the pacemaker, but we also check whether it's medically necessary. And sometimes the imaging is not really necessary, or they can use other imaging modalities to get the answer, or they don't really need the answer and can just watch the patient clinically. We do have MRI cardiology staff there during all of these MRIs to check on the patients. And if they need any reprogramming of their device after the MRI, they're right there to do that on the same day. So it's a very nice, very safe program. The
Absolutely.
other question that comes up is MRI and pregnancies. There used to be this fear that it's not safe to put pregnant patients on the scanner or pregnant workers in the MRI suite. And sometimes when knowledge like that has prevailed for a long time, but it's changed, this change doesn't come in quickly. So people still have that old notion that there is some sort of risk. So what would you say about pregnancy and MRI?
Yeah. And along with that, even when a change comes, it's sometimes difficult to implement change. So I totally understand, and it takes some time. But as of right now, the ACR and their recommendations, they say that there is no risk or concern on having a patient not only be in the room who is pregnant, but even scanning a patient who is, there's no concerns or risk or nothing that has come from that we can say it's directly attributed to scanning the patient. That being said, now when you go into the issues with contrast, that's a little different. Before, and this is another thing that's dealing with the change, before it was if you were breastfeeding and you gave contrast, they said to pump and dump, or they've even done away with that. And that's something that's it's still in the new stages. But regarding pregnancy, there's no concern that has proven from actually scanning a pregnant patient in an MRI.
Okay.
So it's a great alternative for any other imaging.
Yeah, yeah. And we do fetal imaging all the time, and it's super helpful to assess some of those fetuses. Then the other type of injury, we give earplugs to patients. Why do we do that?
Yeah. So one of those energies that I mentioned, this is one of the weird ones, the gradient field. This is the one that actually sends those electrical voltages through, if somebody has a CIED, through the leads. This is also the ones that's dealing with peripherally nerve stimulation. So sometimes you get patients going to the scanner and they say they feel like their skin is tingling, or they get these effects of being dizzy. The gradient field is attributed to this, and along with the noise. That's the biggest thing. The noise is this gradient energy. And this particular one has, I think that over time we'll find out that, I know you've seen those commercials where they say, have you or your family member been affected by X, Y, and Z? I think that technologists being around all this noise all the time, after a while, it may affect the hearing because it is loud. Gradient coils in MRI give anywhere from, I think it's 65 to 95 decibels. And just for context purposes, a rock concert is about 110 decibels, right? So it's extremely loud. Earplugs and headphones are definitely recommended. And that's specifically for the gradient energy because of those gradient coils are very loud. Yes.
Yeah. And we do like the gradient imaging because it makes nice pictures and it's really good.
It does. And I mean, this is really the gradient coils. All they are is really just big speakers. It's just taking vibrations, and it's just really big speakers in the scanner. And that's how it helps the images. Like you said, we get some really good pictures.
Yeah. The last thing I want to talk about, and that's also complex, is the risk of burns in the MRI. So there are several situations where these skin burns can occur. Can you talk a little bit about that?
Definitely. And this is referring to that third energy, the RF radio frequency. The vast majority of the burns are really due to this radio frequency energy. And what happens is similar to a current, and the electrons are going through this circular current path of least resistance. It's always just going to keep flowing and flowing until it hits somewhere where they hit some resistance. So if you can think of a big circle, if you have the big circle being from your head down your arms and to your fingers that are crossed, your fingers that are crossed, because it's not that big highway of your arms, it's not that big highway of your chest, and your fingers just barely touching are that traffic jam, that 5-lane highway turning into one. That's the area where you have the high likelihood of getting burned, right? And this is from that RF energy, the electrons just trying to find a way to cram through. That's where you find that area being burned. So that big circular, the big circles, small circles, if you think of the patient's inner thighs touching, that small touching area, that also is subjected to a lot of burns. A patient just grabbing their elbows in the scanner, them touching their elbows, another place for getting burned. I actually heard the story of a gentleman who had a particular type of cancer on the inside of his thigh. So he had a lot of muscle mass removed. So his thighs never touched. But because he was running a lot and working out a lot, his calves actually touched. And right at that point where his calves touched, because they were so muscular and big, that's where he had those burns. So alongside that, you also have big circle in the tube, the sides of the arms of the patient touching the sides of the bore. Another point of where, that just that touching can cause that RF burn as well. There's always recommendations for padding 1 to 2 centimeters, 1.5 to 2 centimeters is the recommendations of padding. Sorry to a lot of the MRI technologists, but just putting a sheet around the arms is not 1 or 2 centimeters, right? You actually need specific paddings to prevent these burns. And these are placed in between the thighs, under the arms, all of these places where the skin is lightly touching will be the best place to put this padding.
Okay. And you mentioned before fibers and clothing, and that's why we ask the patients to really take all their clothes off. Sometimes there's little metallic components in the fiber that is not listed on the label, or it's not visible, but it's in the fiber, and that can be dangerous. And then tattoos can heat up, and sometimes we use cooling pads or ice packs if it gets too hot. Can they burn also? Is it dependent on the size of the tattoo, or?
They can burn. It's mostly dependent on what the tattoo was made out of, right? What the ink was made out of, which if you ask anybody, they don't know, right?
Yeah.
That's when they go to a tattoo shop and they get a
Right.
tattoo, and that's all I
Yeah.
know.
Yeah.
A lot of the ink nowadays has been filtered and it goes through a whole process and approval process right through the FDA. So that's a little different, but believe it or not, we have a couple patients who have gone through the prison system, right? And that ink in the prison system is not going through that process. And it does have some metal within that, and that can definitely cause burns. So the size of it wouldn't matter so much. It does matter where it is on the scanner. If you're scanning, for example, a head and it's on their ankle, I wouldn't be concerned. If it's on their chest and you're scanning a cervical spine, I would be strongly concerned. Where did you get it? How long ago did you get the tattoo? So those are points that we do have to ask. And along with the clothing, like you mentioned, you just don't know, right? A lot of these clothings, they have these metal shards in their clothing. To be on the safer side, it's always recommended to have them change.
Yeah. And then I think nowadays people also get metallic things implanted in their body. And there's a word for that, I don't know, but it's these extensions, things like a little magnet under your finger.
Yeah.
There are certain transdermal patches that can be a safety hazard. So I know where we look for those. And maybe as a last point, can you talk a little bit about monitoring equipment like EEG leads and other things? Can those go in the MRI scanner?
Yeah. Yeah. So we have specific equipment in the MRI room that is permissible to be actively on the patient while scanning. Anything from the floors, those little leads, they have caused burns. And a lot of the times, if a patient gets picked up, for example, by an emergency EMT, they're monitoring them and they're putting leads all over their bodies. So that's why the visual check that I had mentioned earlier is very important, especially in a trauma hospital or any hospital, really, just to check the patient's body to make sure they don't have these leads. Now, the wires that are all on the floors, we have to change them out to our equipment, which is why, if you can imagine a ICU patient, it can be a lot of work to bring them down to MRI because you're switching out all of these equipment. So it's a lot of work, but we do have the equipment necessary in MRI, whether it's respiratory, whether it's an anesthesia machine, whether it's ECG, all of these leads, the pulse ox, even to monitor CO2. We have all of these things available within MRI departments. It requires a lot of work to switch these patients out, especially who are require critical care. Just we do have to keep that in mind. And then also the leads, even within MRI, that are the wires from the EKG, we put padding under that because if that's directly touching the skin, that's another loop from those occurrences.
And then the very last thing, which you mentioned earlier, but we want to touch on, is the quenching. So we always get trained for what do you do when the quenching happens? And I know I think more modern scanners, quenching is not so much an issue. Can you talk a little bit about this quenching? When can it happen? What do we do? When do we want it to happen? And is it something in modern scanners that we still have to worry about?
Yeah, so the quenching, pretty much what that is, we have this flow in the machine. We have these electrons constantly moving. And if you move anything over a long period of time, what happens is if I move my hand on the table after a long period of time, it's going to generate heat. So in order to prevent this heating up from happening, it's quenched in this tub of liquid helium. Liquid helium being extremely cold, negative 456 degrees, I think, and it's very expensive, right? All of this liquid helium is bathing these electrons to prevent it from heating. If you're quenching a magnet, it has to be for a life or limb threatening, right? If it's a really bad uncontrolled fire where you're going to have fire department coming, go ahead and quench it. If somebody's pinned to the machine, go ahead and quench it. If somebody's having some sort of issue where they can't move in the machine and it's because of an object, go ahead and quench it. So anything life or limb, I wouldn't hesitate to quench. Other things like things getting pinned to the machine, we can ramp it down through the field service engineers. But this quenching process, what it does, you press a button and it sends a small electrical charge to this pretty much box where all of this liquid is, and it turns it into a gaseous state. So this gaseous state, it goes from being usually is from about 14 to 1 from its liquid to its gas state. So it's a lot of gas that gets expelled through the pipe, and it goes on for hours. It's very cold, obviously. The facilities especially has to be familiar with what is done in this situation. But that's what the quench is really. It's just taking that liquid to that gaseous state. And again, life or limb situation. Now the newer scanners, which is really neat, it goes from having about 1,700 liters of liquid helium, which is what a lot of the scanners have, to about 7.
Oh,
Um,
wow.
which is just, it's mind-boggling. And now even there's some that you can do a inside quench to where you quench it, but then it stays within so that it doesn't expel all of it, and it's just for a couple of minutes or hours, and then you can continue on with scanning. MRI, I tell you, it continues to evolve. Being from the 80s, it's relatively young, even though some people may not consider that relatively young, but it's still evolving. And I think that we're going to get to a point where, I know that there was a time where liquid helium was very rare and we didn't really have many of it. And here in the United States, I think it's going to come to a point where we won't need it as much. So yeah, that's the quench process.
Okay, great. I learned a lot from you, Stephen. Thank you so much. You're such a brilliant expert on this matter, and I'm so happy that we have you on our team and you're keeping our patients safe. And you've really made so many great changes to our MRI safety program. Any other things that you would like to share with the learners?
No, I appreciate everything. I appreciate this opportunity. I think that MRI is something that, like I said, it's growing. I think that, especially here in the United States, I want to make sure everyone is aware that it is something where people didn't have many options to do before. You only had an option to do an MRI in a hospital or maybe 1 or 2 clinics in your area that offered it. There are MRI centers opening left and right and throughout the country. And I think that's important to know because there's a bunch of risks involved with it. People just see it as, hey, it's similar to X-ray. And anyone you ask, have you had an MRI? Yeah, I think I had a CT before. That's not necessarily the same
Yeah,
thing.
that is not the
But you have a bunch of these centers opening. You have a bunch of these locations that are unique environments. You have intraoperative MRI, which we didn't even speak about. That's totally unique and different within itself. You have PET MRI now, right? So it's continually evolving, but the basics of MRI safety with those 3 fields and their concerns are things that I really like to drive home anywhere I go. And I think it's super important for anywhere, any healthcare institution that has these machines. Yeah.
Okay. Thank you so much, Stephen. And with that, we end our podcast for today. Thank you.
Thank you.